My name is Jackie Wooden, and this is my virtual case presentation. The first step of the telehealth visit is to introduce myself to the patient and get their name and date of birth. Next, I'm going to obtain permission for treatment and discuss expectations for the visit. This patient identifies herself as Jane Doe, date of birth January 1st, 2001, and she does verbalize consent for treatment. I explained to her that today I'm going to be asking her a lot of questions, identifying a diagnosis and offering treatment options, and education regarding that diagnosis and treatment. In this next part of the visit, I discuss the history of present illness. Using old carts, we discuss onset, location, duration, character, aggravating and relieving factors, related symptoms, and then timing of the symptoms. The patient's chief complaint is, I've been feeling down for a while, and my mom finally made me come in. She reports her symptoms began about 6 weeks ago after she was fired from her job, and things started spiraling for her. When asked about location of any physical symptoms, she reports occasional stomach pain and exhaustion. She does say that she's been sleeping more than usual, but finds it oddly hard to fall asleep because when she's laying in bed, all she can think about is what a mess her life is. The character of her symptoms are described as a sad, empty feeling. For duration, the patient states that she feels this way nearly all the time unless she is busy doing something that takes her mind off of it. Aggravating factors include overthinking her situation, and alleviating factors include doing something that keeps her busy. Other related symptoms are decreased appetite, anhedonia, fatigue, inability to concentrate, and she reports that her symptoms are no different at any time of the day, but the holiday season has made things a little more sad. At this point in the interview, I asked the patient about any past personal or familial medical or mental health diagnoses, any current or previous medications, over-the-counter or prescription, and then any interventions for any of these disease processes in the past, and if what's worked and what hasn't worked. I asked the patient if she or her family have any cultural or spiritual needs that we might consider when deciding on an approach to treatment. This patient denies any medical history or current over-the-counter or prescription drug use, but she reports that she went through a tough patch right after high school after a fallout with a friend. She does report that she was treated with Prozac for a little over a year, which really helped, but she felt like she didn't need it anymore, and so she stopped taking it. She reports that her mother's mother had diabetes and hypertension. Her mother's father had heart disease. Her mother has a history of depression and is also on an antidepressant, and has been since her father died from prostate cancer a few years ago. The prostate cancer is the only medical history that she has for her father. She doesn't have any information on her father's parents. She reports that she does have a sister who was diagnosed with depression and anxiety, and she takes a medication that helps both, but she's not sure which medication that she's on. It's important to discuss the patient's social history, including any current or previous drug and alcohol use, education and occupation, living situation, and social supports in place for the patient. She reports no history of drug use and drinks occasionally, stating 1 to 2 drinks monthly. She reports she graduated from high school on time but waited until she was 21 to start college, which has been very difficult for her and is taking longer and costing more money than she planned. She's currently in nursing school, which is causing her a significant amount of stress. She was fired from her job waiting tables recently for being on her cell phone too much, for which she blames both her studies and her boyfriend, who she's been having a lot of problems with lately. Her living situation is stressful. She was living with her boyfriend, but after being fired from her job, she had to move back in with her mother because her boyfriend and his roommate were not willing to cover her part of the bills until she was able to get another steady paycheck. She is close with her mom and sister and has become really close with their nursing school friends, but feels like she has too much drama to really talk to everybody about her issues. She also feels like she's too old for this kind of drama, and she's embarrassed that she's not further along in her life at nearly 25 years old. A quick review of systems is needed to rule out any medical causes of the chief complaint. I do a quick head-to-toe assessment asking about each symptoms. And then, of course, vital signs and a pain assessment are included in this review. So the patient denies any new physical symptoms besides the occasional stomach pains. We went over neuro, respiratory, cardiac, GI, GU, integumentary, and musculoskeletal. And again, the only thing that she reported was the occasional stomach pain, her exhaustion, and then just the sad, empty feeling. At this point, a PHQ-9 is administered, and this confirms a current depressive episode. And then we move on to the mental status exam. So the patient is alert and oriented, but admits that she feels some brain fog and jokes that she usually can't tell me what she had for dinner. Her concentration is impaired, notably. Physically, she looks tired. Her mood is sad. Her affect is tearful and anxious at times. Her speech is monotonal and kind of slow. Thought process is ruminative. Her thought content is without SI, but she does report feeling hopeless with few coping mechanisms. And when we discuss SI, she vehemently denies any current or previous SI, and she stated that she would never do that to her mom and sister. She's never had a plan or even just wish she would go to sleep and not wake up. So abstraction and insight are intact, and she is self-aware. Differential diagnoses for this patient include adjustment disorder with depressed mood, depressive disorder due to another medical condition, and bipolar disorder, current episode depressed. But the presumptive diagnosis for her is major depressive disorder recurrent, and I added a little specifier on there with moderate anxious distress. So in order to meet criteria for the DSM-5 criteria for major depressive disorder recurrent, she has to have 5 of the criteria. So she has 6. So she has depressed mood, loss in desire to do things that she enjoys, or anhedonia, decreased appetite. She's not lost any weight, but she did say that she just doesn't feel like eating. Hypersomnia, fatigue, and inability to concentrate. So that's 6 of the criteria, and she only needed 5. Now the specifier, because she is tense, she's restless, and she's unable to concentrate due to worry. That's 3 of those criteria, so she meets the specifier for moderate anxious distress. Again, it's essential to rule out any medical conditions that could be causing her symptoms. This patient had labs the week before her appointment. She had a CBC, thyroid function panel, B12 and folate levels drawn, and these are all normal. And the reason we would do a CBC is to rule out any infectious process that could be causing symptoms like mono. Thyroid labs are going to rule out endocrine disorders that can mimic depression. Looking at B12 and folate levels are going to rule out nutritional deficiencies that might be responsible for her symptoms. And then, of course, before starting any medications, we're going to assess for any allergies to any drugs or substances. And this patient reports that she does not have any allergies to any drugs or other substances. A nice quote from one of our textbooks is, "The relationship between the psychiatric mental health advanced practice registered nurse and the client is the foundation for any assessment or intervention." And so I think this means it's important to include the patient in any decision making about the treatment. So I did educate the patient about SSRIs and informed her that their first-line treatment for major depressive disorder, because this patient has had success with Prozac in the past, but she's showing some moderate anxious distress now with her depressive episode, I felt like Prozac was maybe not the best choice. This is because I've learned in my very limited clinical experience that Prozac is one of the more activating SSRIs. The least activating SSRI I've learned is escitalopram. So if taken at night, The escitalopram could help the patient fall asleep without that nighttime rumination that she's been having. So I'll prescribe escitalopram 10 milligrams at night. I'll prescribe a 30-day supply, and if needed, we can increase to 20 milligrams. Escitalopram is the generic of Lexapro. So having a generic medication, automatically you're going to assume that's a cost-effective option. And one study did show that escitalopram was cost-effective and well-tolerated. So I do feel good about prescribing this medication, and so did the patient. Psychotherapy is also recommended, which the patient is open to. The psychotherapy, this is going to offer her some coping mechanisms that will help her greatly with her depressive episode. Education points for this patient are going to be focusing on informing her about her diagnosis, which is major depressive disorder, and the medication that we are prescribing for her, escitalopram. So I'm told her that major depressive disorder is among the most common mental illnesses, and it affects mood, motivation, sleep, appetite, and thought process. SSRI is first-line treatment along with psychotherapy. We discussed psychotherapy is going to be very beneficial for her to learn coping mechanisms. Now, it's important that she gets adequate rest and nutrition, and exercise can help her tremendously as well. Regarding the medication education, I want her to report any increased anxiety, irritability, or agitation. We discussed at length that SSRIs can cause activation in patients with undiagnosed bipolar disorder. She's very well aware of that. She said that she took Prozac, which is one of the more activating SSRIs, a few years back, and she didn't have any of that with the Prozac, so we're not expecting any of that to happen. But she also knows that she might experience some nausea, diarrhea, dry mouth. She knows to take the medication as prescribed, and not to miss our follow-up. That she's going to notify the provider right away if she begins experiencing any SI. We discussed at length that antidepressants in general, but SSRIs can cause SI, and that's just something that we want to keep a really close watch on. Because escitalopram can take 2 to 4 weeks to work, I want to see this patient back in the office between weeks 3 and 4. I feel like that will have given her a little bit of time to see, how this medication makes her feel. Is she experiencing any side effects? Do we need to increase her to 20 milligrams? For a referral, I'm going to refer her to our therapist in-house, unless she has someone in mind that she already was thinking about seeing. But definitely follow up between week 3 and 4 and refer for therapy.